after operative ankle treatment. It's a prospective randomised control trial from Ireland that was published in 2007 in Foot and Ankle International. So just as a bit of background, as we all know, the AO principles of fracture management include reduction, fixation, preservation of soft tissues, and finally early mobilisation. Over the past 10 to 20 years, there have been a range of studies put together looking at mobilising ankle ORIF patients early on rather than the traditional 6 weeks in a below-knee plaster and immobilisation. And this is where the studies are starting from and looking at trying to give us a clearer indication for when we can use early mobilisation. The purpose of mobilising joints early is to restore range of motion and also to decrease swelling, atrophy and longer-term complications. So the aim of this study was to compare the outcomes of ankle fractures managed by internal fixation with either early mobilisation at the 2-week mark, so allowing for primary wound healing and then starting to mobilise them, or for 6 weeks immobilisation in a below-knee plaster. The process included 66 consecutive patients that were admitted between August 2004 and March 2005 who had presented with an acute closed ankle fracture that was managed operatively. They only included, they included all age groups between 14 and 65 and all types of ankle fractures, but excluded those such as pylon fractures and isolated medial malleolar fractures. After collecting the 66 patients, each of them was randomised using their date of birth and were allocated to either an early mobilisation group or an immobilised group. So this included first 2 weeks in a plaster to allow for primary wound healing in both groups. And in the early mobilisation group, they then went into a removable plaster, removable fiberglass cast, where they then underwent regular physiotherapy. Whereas the immobilised group went through a routine 6 weeks in a plaster. At the end of 6 weeks, the patients were then allowed to partial weight bear, progressing to full weight bearing by the 8-week stage. So just to go into a bit more detail on the early mobilisation group, as I said, they had this removable fiberglass cast, and 3 times a day they were allowed to remove the plaster and mobilise their ankle. This just included active and passive range of motion exercises and were done with a physiotherapist. The patients were followed up for a total of about 24 weeks, and the following outcomes were collected at these assessments. First of all was a clinical assessment by one of the authors of the study, which included looking at ankle swelling using a tape measure figure of 8 method, wasting of the calf muscles by measuring about 10 centimetres below the tibial tuberosity, comparing their initial calf circumference to the circumference at the 6-week or 12-week post-op assessment, and finally active range of motion. At the 9 and 12-week mark, each patient was then asked to, each patient was then completed the two scoring systems, the Oliwood and the American Orthopaedic Foot and Ankle Society scoring system, which are both validated scoring systems. They also were assessed for whether or not they'd returned to work and had a posted we posted out a quality of life questionnaire at the 6-month mark. And finally, complications were also collected. Statistical analysis for the trial, they did not include a power calculation prior to commencing the study. And overall, using Mann-Whitney U test and student t-test, the study was large enough to show some statistical significance between these 3 clinical assessments. So as I said, there were 66 patients recruited. 4 of them were lost to follow-up, and they were not included in the final analysis. 2 of those had not been complying, and the other 2 were lost to communication. There were similar characteristics between the 2 groups overall, but there was nothing documented there about comorbidities, sorry, you can't see that very clearly on this. All they had really compared was the age, the BMI, and the type of fracture that the patients had. And then I'll just go through briefly their results from the study. First of all, the clinical assessment, which you can't see very well on this either, sorry. So basically to summarise that, there was no significant difference between the ankle swelling at the 6 and 9 week mark, but there was some difference in the early stages between, a significant difference in range of motion, dorsiflexion and plantarflexion at the 6 week and 9 week post-op assessment. And there was a significant difference in calf wasting as well. There we go. It's thought that at least 10 degrees of dorsiflexion and 15 degrees of plantarflexion are needed for normal walking, and this was achieved by the majority of patients at the 6 week mark in the early mobilisation group, but only 1 out of 29 patients in the immobilised group. However, it is predicted that overall the range of motion would increase as the immobilised group progressed into their physio over the following months. I'll just skip that because you can't see that, but basically the functional outcome measures, so those 2 scoring systems, there was the paper said that there was a significant difference between the immobilised group and the early mobilisation group of with a p-value of less than 0.05. However, looking at their actual results, their confidence intervals overlap. So I'm not sure how we can really take that information on board. And that's just a graph which I'm not sure if you can see very well. So the white bars are the immobilised group, and the black bars are the early mobilisation group, and it's the functional scores, which the maximum was 100. So there you can see a slight difference at the early stage between the 2 groups. And finally, their quality of life score from a posted survey, there was no significant difference between the 2 groups at the 6-month mark. Overall, the early mobilisation group returned to work a mean of 67 days, with a mean of 67 days. And again, there was a significant difference shown by the study, but with such wide confidence intervals and with them overlapping, I'm not sure how accurate we can take those results. Am I talking really quietly? Because no, I'm okay. I am? Oh, sorry, because I can't hear, because this is, oh, all right. I don't usually talk that, anyway. So finally, the complications of the 2 groups, there were 2 DVTs found in the group that was immobilised, and 3 wound complications in the group that was allowed to mobilise early. Of those 3 wound complications. 2 of them were deep wound infections that eventually required removal of metal and admission with IV antibiotics. But of note, those 2 patients, one of them was a 16-year-old who apparently had some eczema and some skin changes early on, and the second patient was non-compliant and was a smoker as well. So looking at the overall analysis of the study, I thought that the study was well laid out but had poor precision. It was randomised and prospective but not blinded, and the groups were overall similar at baseline and had similar treatments, or had similar treatments apart from the early mobilisation. They did not use intention to treat, and finally the outcome measures were again the outcome measures were not blinded to the person that was assessing them and putting together the scores. As I said before, they had no power calculation, so it's difficult to interpret their final results where there was no significant difference. And they didn't really describe where the source population, which hospitals they went into, or where they came from. Otherwise, it was well described in terms of their inclusion and exclusion criteria. Also, the study didn't stratify for other comorbidities or put that kind of information together, which I think is important when looking at issues such as wound healing. In comparison to other studies, there has been a Cochrane review done in 2005 on a similar issue, on a similar topic. This wasn't really included as a reference for this study, but the Cochrane review had very similar conclusions where patients with early mobilisation have reduced activity limitation, reduced pain and improved range of motion, but they are at risk of increased wound complications in the early stages. Another similar study from the JBJS in 2003 looked at 100 patients with Weber A and B fractures, and they were also randomised to early mobilisation or immobilisation, but in this early mobilisation group they were allowed to start range of motion activities almost immediately after surgery. They had far more complications than the study where immobilisation was only commenced after the 2-week healing phase. So in conclusion, selected patients managed with early non-weight-bearing mobilisation after primary wound healing post-ankle internal fixation may show short-term improvements, but may risk early wound complications. That's it.